And it says right there, Carol, we are live. Carol, welcome, welcome, welcome to our Tea Talks with Total Health. It's so good to have you here today.
I'm so excited, Sharon, to be here. And thanks so much to the Total Health team for the invitation. One of my favorite things is to talk about a lot of things related to health. Kansas, I'm a Kansas farmer daughter, so rural health is important to me. And I'm always very excited to share any kind of information and tools about palliative care.
Yes, absolutely. And you just said something about rural health, and I want to get into that because that struck a chord when you said that. I guess one of your friends, Corey, is saying hi, Carol. Hi, Corey. Thanks for joining us. Carol, I know you just rambled with that about the country girl and stuff, but tell us a little bit more about who you are, because I know you were recommended to me by one of the members of our team at Total Health. Like, you got to get Carol on this show. So I know you're highly thought of there as well, here at Total Health as well. So, but our audience may not know you, except of course for maybe Corey. So tell us a little bit more about yourself.
Sure. So I am from a small farm, actually south of Wichita, Kansas. So I am a Kansas farmer's daughter. And I grew up in a family that were all about advocating for policy change, for improvements in the community, which included rural economic health as well as physical health. My first degree is in ag journalism. So as you might imagine, messaging, plain language writing and communication have always been important to me. And then when my children were all under the age of 5, I went back to school and I got my degree in nursing. And that was in the early 90s. As you might imagine, I'm practicing in rural Kansas, but I always found a way to capture the stories of individuals and share those as well. And because I had the background as a journalist, really being able to share complex information in plain language ways always was really helpful for me and for patients' families and their circle of support. So I would say that a lot of things that I've done over my career, and I've had a career as a nurse in Kansas for over 30 years. The predominant part of that was practicing in oncology, nursing. So in the community oncology level, as well as through clinical research, and also as a stint as a nurse consultant with the University of Kansas Cancer Center, which is a comprehensive cancer center. And a lot of that was working with our community cancer centers across the state to develop nurse navigation programs. Life experience, a few years ago, right before the pandemic, my husband was diagnosed with prostate cancer. During that same week, my father, 85-year-old Kansas farmer, toting bales all over, did have a stroke. And I started a new role with an advocacy organization. And then the pandemic hit. So that colored a lot of my experience, because in the advocacy organization, I heard the moral distress of my colleagues in the community and in the hospital setting. Second, as a skilled and knowledgeable nurse navigator, I needed to navigate my own parents' journey in supporting their goals. Where are they going to live? I knew of palliative care, but not what our community had. And so all of those experiences then led me to transition actually to my encore career, my encore specialty as a palliative care nurse. So that's like a 30-year trajectory in a very short period of time.
Wow. I hope your husband and dad's doing good. Okay.
So my husband is doing well. He had stage 1 prostate cancer. So we still had a lot of decisions to, work on together. And my father, he actually did pass away this last October, but we definitely had a lot of goal setting conversations with our team, with his primary care physician. We had the ability to engage community-based palliative care. And then later, when he decided he did not want to, seek any kind of care in the hospital setting, he made that transition through hospice and lived strong through to his last breath. So it was absolutely, both services, wonderful.
Okay. Well, sorry to hear about that. My condolences. But I think that segues us into that conversation, right? When you and I spoke before we got on this call, I was asking you this question because from my own knowledge and just your beautiful story about your dad and from palliative to hospice, what is the difference? Because I think I said to you, Carol, when you are a young patient and you have maybe a chronic illness and the doctor says maybe you should get some palliative care. In your mind, you're thinking palliative care means the doctor is seeing that my prognosis is bad and I'm going to die. And could you explain to us the difference between both palliative care and hospice care?
Definitely. So the great news, again, just really harking back to my journalistic and messaging kind of background is it's really never too early for palliative care. So palliative care is actually specialized medical care for people dealing with a serious illness. And it is delivered by a team of specialists that might include physicians, nurses, and other clinical professionals like social workers, chaplains, etc. So the goal of the palliative care team is actually to improve quality of life, managing symptoms, which include sharing information and coordinating care for a person dealing with serious illness and their circle of support, which may include family. So a lot of us have non-traditional circles of support. The great news is that palliative care is appropriate at any age and any stage of illness. And so that's a key differentiator because palliative care is appropriate from the first time that you are diagnosed with a serious illness. Actually, even before, because all of our preferences or goals for supportive care, whether they are palliative care, symptom management, or a transition to end of life, and the wraparound care with hospice starts with a conversation, understanding what are a person's values, what would they want. And so really palliative care starts with us. Each one of us understanding what our goals and preferences are. And, over thousands of conversations with individuals and their loved ones. One of the next questions people often ask are, okay, you already said it's appropriate at any age and any stage. So it is when I'm pursuing curative treatment, yes, you can have palliative care. Where do I receive palliative care? So the good news is, just like end of life care, palliative care can be delivered in the inpatient setting, in the clinic, or wherever you call home through benefit of home service agencies, or guess what? The thing I'm most excited about, telehealth. So we can also have access to palliative care through our specialists, again, inpatient setting, in the clinic or community or home. And so you will hear at home, we refer to that as community-based palliative care. And another question people also ask, will my insurance pay for palliative care? So a short answer is yes, but it's not perfect because most insurance plans including Medicare, Medicaid, and private insurance, will cover palliative care. The way we deliver or pay for palliative care in our country are three models typically. So I will call the first model and most popular is philanthropy. Inpatient teams are often philanthropy based, especially if they are nurse-led teams. Physicians, through the visits or consultations, do have a mechanism for billing.
When you say philanthropy, Carol, what do you mean by it? Do you mean that some rich person is funding this outside of the patient, or is that what you're saying?
So I'm saying that it's actually the philanthropy of the healthcare system is investing time, talent, and treasure. So they are supporting fully the palliative care team, clinicians, and all the work. So you will see that often in healthcare systems, and predominantly in the inpatient setting is actually where first you will often see palliative care. Then in our community-based models, that's where even our home service agencies may choose to support their team and not bill for service, because the billing is, I'm just going to be transparent, it's pretty wonky, because in hospice, we have a defined hospice benefit and payment structure that includes the whole team. We need a defined palliative care benefit. That's why I am an advocate for any type of CMS, I guess pilots. And we have a lot of those really launching right now. And you'll see in the oncology community, as well as other serious illness communities like our heart issues, et cetera, we're really looking to, kind of wrap that up and define clearly a payment in there.
Is it wonky and undefined because it feels kind of gray? Like whereby hospice feels like hospice, right? We know the outcome here. Is it wonky and undefined because it feels more like gray? So in other words, what is involved in that palliative care? You said it's kind of curative. Is it symptom management? What are some of the things that you do?
Sure.
Yeah,
that's perfect. So sometimes people, the great question is, what can I expect from palliative care, and how do I know if it's right for me? So first, I think, well, how do I know that I'm eligible for palliative care, and what includes a serious illness that you're talking about? So that serious illnesses may include if you have cancer, but other illnesses like heart failure or heart disease, lung disease, kidney failure or kidney disease, neurocognitive illnesses like Alzheimer's, dementias, including multiple sclerosis. Palliative care, again, is going to be focusing on managing your symptoms of those diseases, and also really helping you meet your goals. And most people say, to me, in a nutshell, they say, my goal is I want to live strong and as independently as I'm able and have my symptoms managed and also I want extra support for my emotional needs, not only myself, but my family, and help navigating any next steps.
Okay.
So I think, and then when you said that people might want to understand, what can I expect from palliative care? We talked about relief from those symptoms, but that might include pain, shortness of breath, fatigue, a lot of things that we think about: nausea, constipation, difficulty sleeping, but also, again, what we see in our country also, our circle of support looks different, but some people have no one. So the palliative care team then connects to community resources, and because we do often work with behavioral health professionals and have social workers, we're able to provide emotional support and just a listening ear as they're concert with their specialists and their family practice physicians when they're making those next decisions. Do you think that maybe helped a little bit?
Yes, yes. And I know there was a question earlier. I'm going to put it back up. But before I put that question back up, as you're talking about palliative care, which sounds like an amazing benefit to me, right? And let me put this question up, and then I want to come back to something else. I think the question here was asking, at what point should patients consider hospice over palliative care?
So I think earlier in our conversation, I said everything when we're looking at goals starts with a conversation. So really first understanding from patients and families what matters most to them and helping them explore some of that. But definitely I feel, and that's why my motto is, and I tell residents and student nurses and attending physicians all the time, because I practice in an inpatient setting. My motto is, it's never too early for palliative care, because we want to help people be informed and get on the front end. And part of that, knowing when to transition to hospice, depends on, number one, a patient or their decision maker. So some people might be more advanced in their illness, and frankly, because of their disease or overwhelming infection, they're not able to make a decision. So they're a surrogate decision maker. But understanding what their goals are, and if they're focused on, I want to live strong, have my symptoms managed, but you know what? I want to start eliminating some of these pokes and prods and tests. And people often say, I really don't, I love you guys. I love the hospital, but I want to receive my care totally at home from now on. So it begins with patient preferences and goals. There is one criteria that for the hospice benefit, it would be that a physician and your family physician is identifying that given the normal trajectory of your illness, your life expectancy might be about 6 months or so. So that's the, I will say, the paperwork mark.
Got you. So as you're talking, Carol, I keep thinking, because at Total Health, one of our focus here is health disparities, right? Ending health disparities, because we believe that everyone, should live their life to the fullest, equitable treatment. So I'm thinking, in your experience, is this benefit being afforded to minority groups, or you're from the rural area, the poor, the social, the disadvantaged, the economically disadvantaged? How do they get into this equation? It seems like a wonderful benefit, but I'm just wondering how many people are exposed to this.
Right. So the challenge with our healthcare system is we've not done a great job at cultural humility, and also that even access and understanding that these types of support services are available. I can access it in my community. I can call someone directly. I don't have to come to the hospital. So all of those elements, and also because some of in our culture, and also here, I'm wearing a white coat, right? When I wear this, I have to be very careful, because a lot of people have fear and do not trust the healthcare system, and this denotes to some people, they're like, oh, you are a nurse practitioner or you're a physician. But nurses with advanced skill sets in our health system wear white coats. But I do need to be careful, because I'm earning someone's trust. And so understanding not only where the geographical region is that our folks are coming from, but how are they able to access care, and also generationally, the racism and distrust that our society has in place puts many barriers up, and we need to, as healthcare professionals at a foundation, and definitely as palliative care professionals, really be aware of that. And so I think that's why it's imperative. And just for me personally, as someone who loves messaging, it's hard to scale information internally, right? I want everyone to know about the hospice benefit, about palliative care, that it's never too early, that there are resources for support, whether you can you have insurance or not. There are many agencies that provide community support, um, because of their own impact and investment. So it can be pretty challenging, but we do things like this, right? We use our voice and our partnerships to help people know, yes, you don't have to walk alone. There are resources. And the great news is, just in my own practice as an oncology nurse for over 30 years, yes, I knew of palliative care. I did not know the depth of our expertise in the community and the hubs in the rural state that it is available until I became a certified palliative care nurse. And I'm one of 55 certified palliative care nurses in the state of Kansas.
Wow. It's still a growing
field. Right.
Still a growing field. And just what you said, Carol, it's such a wonderful, unique benefit, and it's definitely not widespread, right? And so, again, I'm just thinking in my head, wow, the working poor or the uninsured, the underrepresented, they're obviously not part of this conversation at all. I'm not even sure if this kind of stuff is even mentioned in their standard of care, especially as, you talk about like pain management and quality of life. And, this is something for sure. I'm glad we're having this show, and we'll have more conversations where we're getting the word out about this stuff, because as you mentioned earlier, it's not covered by insurance, kind of. It's not really that black and white. It's very wonky. So forget that box, right?
It's not linear, and it's not, there's not this nice little algorithm.
Yeah.
The other thing I think why for me, and what I see across the country in palliative care specialists, we're a lean, mighty group of specialists. It's a very warm, inviting community and very culturally, we are very inclusive, but we still have a ton of work to do. But as individuals, we're also very, very involved in advocacy, not only in finding ways that we partner with community organizations like our faith communities, and public health and preventive health organizations, because we want to start the conversations early and help people be informed. And personally, that's also why I feel very blessed that I've built some strategic relationships, and I'm very proud to serve and to be legislative appointed as a member of the Kansas State Palliative Care Council, and in turn are able to invite diverse voices to the table, representative of our region and the people that we are serving. I want to make sure voices are at the table, that people can say, that person looks like me, and I can get palliative care, and we want to make sure they're all representative. So I think, again, that's why advocacy is huge and important.
Well, that's good, Carol. I'm so proud of you for saying that, because it's so important, like you said, to look around and say, there's someone representative here. And it takes a brave soul to do that. Now, Sarah has something here to say. She says, I want to live well, in quotation. This is the desire of so many of us living with critical or chronic disease. And Sarah has been very transparent with her disease. I love that Carol always thinks first of how the patient lives outside of the clinic, her work is so impactful.
Well,
So
because also no, I'm so happy we have hospitals, right? But
yes.
100% of the people I talk to, they don't want to be here. Everyone says, what do they want? They want to be home. So again, that's why I'm so thankful that I see technology. I see, enhanced nursing and physician clinicians, mobile clinics, the hospital at home movement. More and more care is being delivered in the home. And actually, my favorite community-based palliative care clinicians to work with are critical care nurses who transition to palliative care, because they are strong advocates, they are experts at symptom management, and they know how to get things done. So I'm really, really excited about that. And I think I want to make sure, because we're talking about resources today, and I'm not trying to, I could talk about this till the cows come home, right? But there are two essential resources. I'm just going to make a call to action for the definitive voice about accurate information for palliative care, how palliative care benefits, how hospice benefits, and then also some advanced training for anyone, is the Center to Advance Palliative Care, or you'll hear me call it CAPSI. So there's free information, and I really challenge each of your listeners, everyone listening today, I want you to go to that website, and I'd love for you, there is a palliative care 101 for healthcare professionals. I'd love for you to take that course. And then for patients and caregivers, the patient-facing organization is called getpalliativecare.org. So there are tools, messaging, podcasts, and stories from patients who are themselves facing serious illness, and how did palliative care benefit them. So those two things, the Center to Advance Palliative Care, and you can get connected to all kinds of advocacy toolkits, et cetera. And then the patient-facing Get Palliative Care. And my third takeaway is I challenge everyone listening, whether you are a personal caregiver or a licensed clinician, I'd love for you to consider ramping up your skills in conversations. So there is a great serious illness care guide, and you can download that, but it is wonderful because nurses, residents, and caregivers, so people in the circle of support, they always want to know, how can I have a conversation? I don't want to say the wrong thing. So messaging and scripting is important. And I would really love to see everyone take action by learning more about how to have conversations and accurate messaging in real language for folks dealing with serious illness.
Well said. And I know Sarah just posted those in our chat. Peter says, it seems like the proper palliative care that things like ER visits can be reduced. Do you think this can lead to better coverage by insurance because it's more cost effective?
So I think it's really interesting that what we see and evidence shows, and the Center to Advance Palliative Care has all kinds of data and evidence, but the earlier consult or the earlier palliative care teams are involved, the better not only outcomes, but reduced length of stay. And for hospital systems or healthcare systems and insurers, cutting expenses. And also people don't want to be here or in the hospital as long. So the earlier the consult, the better. And actually, having conversations one-on-one in our circle of support, that's the first way. Second way is whomever you go to for care, whether it's a family physician or clinic, family physicians involved in care preferences, et cetera, the best. But our Medicare Advantage and many payers recognize the value of that early palliative care involvement. And it is all about patient preferences, right? So it's actually the right thing to do.
As a patient, if you're a patient and you go to your community doctor, for example, well, what if you say, can you refer me to a palliative care? Is that something that patients are responsible to ask? Because maybe the doctors may not be recommending that.
Right. And that is because we are, as healthcare consumers, right? Or patients ourselves, all of us, even when we're healthy, I want to know, because there's some conversations and I want my team to know what I value should I become ill. But so yes, number one, and people will say, well, how do I get palliative care? Yes, you need to ask. And in the oncology community, we've seen patient preferences drive change, right? Because the whole movement around survivorship care plan is because patients demanded that care. So it is imperative that we do. Our clinicians, multiple specialists, cardiologists, pulmonologists, already have many conversations, but the family physicians easily, I mean, anyone can actually connect you to palliative care. And sometimes people say, well, how do I find out? Where can I find out what community-based palliative care in my community? So good news is on that forward-facing page, Get Palliative Care, you can insert your zip code and identify palliative care services in your area. A caveat is that it's not complete. So I would love to see anyone who offers palliative care in the community not only upload their information, but submit their quality data, because that is also what the Center to Advance Palliative Care does, collect data from the community about the services and care.
Yeah, it seems like there's still a lot of work to be done in terms of exposing, exposure for the work that you do. Sarah asks, and you and I talked about this last week, Carol. How do we destigmatize the fear from the words palliative care and hospice? In so many cases, when I used to work in clinic, patients and families avoided anything around these words because so many felt they were giving up or dying. And that's
So this is a really it's a little bit complex, right? But here are some of the things that I have learned is we do need to, when I talk with families, I help them understand, just like there's a process to the way we enter this world, there's also a natural process to leaving it. And in our country, particularly, we have a death denying society. It's not horrific that we die because 100% of the human race is designed to terminate.
right.
So here's the thing that we can do is we can start talking and keep talking about what ifs of the world, and also using plain language. In healthcare, we're big about acronyms that mean nothing, right? COPD. I mean, it's hard. I still catch myself. And to be transparent about a prognosis, or help families understand you're nearing that. I feel you're nearing a trajectory at the end of your life. Your illness is overtaking your organs and they're not functioning. They are failing. You're at the end of your life. We need to know how best to care for you. So yes, I use dying because that's the only way when people are at that point. And I'm in the place where people are in crisis. In the community, they're not, and in the clinic, they're not always. But it's important we use real language, and we can do it in a loving, transparent way, loving for another human. And that's really what should guide us as we go.
That is so true. These are some, these are some difficult conversations. Sarah says, in our country, we have a death denying society. So well said. When you have people so focused on longevity medicine, yeah, we must learn to die well, to realize that there is a path to peaceful acceptance of our natural world. Um, do you have these kind of conversations? For example, you're not hospice, you're palliative. Do you have a role in saying, I think that this particular patient may need to be transferred over to. So do you have to have those difficult conversations?
Yes, so palliative care, and then particularly in the inpatient setting, we are consulted on cases, either patients and families request or specialists or attending physicians, and often they're in crises, right? And maybe they're making a decision about, I have advanced renal disease. Do I want to start dialysis or not?
Mm-hmm.
What does that mean? Or my mom has dementia, and she's starting to not eat and drink as much. So these conversations, but definitely, do I share prognosis alone? It's a team. It's a team sport, right? Conversation. So I always, in palliative care in the inpatient setting, we always partner with a clinician, whether that is the attending or specialist or advanced practice provider, that can share prognosis. And then we really ask patients, and we're helping them, like, how much they want to know. And often families have a hard time, even though, because we use a lot of acronyms.
Yes.
We might be sharing accurate information, but they really don't know what that means. And they'll even say, the doctors have been talking with me, but I think maybe they're trying to tell me she's dying, and I think she might be. So some of that is just reinforcing again. So a big part of my role, I'm so blessed to work in a teaching facility with residents and nursing students and social work students, and residents love, a few little messaging tips. And I just, my two top tips are: use plain language and treat others like you would want to be treated. You'll never go wrong.
If I should say, there was one theme that you mentioned throughout this whole conversation, was that plain language. I know Peter, latched on to that, because he does our plain language summaries for us. That plain language, so people can understand. I mean, this is their life we're talking about. And when we're talking up here in an already difficult and challenging situation, it's very hard. So I really do appreciate that plain language. And I think Sarah says, finally here, we love you, Carol Bush. So proud of you, so blessed by you. And Carol, as we thank you so much for coming on today and just really educating us on the differences between both, and just sharing with us some of the challenges and some of the opportunities that are still out there. It seems to me, like you said, we need more exposure to this type of work. We need more people involved. We did list your resources. And, we just hope that as people listen to this show, and as you talk and you go on your platforms, that more people are demanding palliative care from their doctor. So there's more of a demand, and that there are more people entering the field as well. Like you said, critical care nurses make the best palliative care nurses. Right. And so, maybe something to consider. You were brought into this field almost because of your own life circumstances, but we're so glad you're here. So as we end this show, what is the main takeaway that you would want to leave with the audience today? Just a quick, Like, okay, if you get nothing out of this talk, get this.
Okay, so, right, my favorite thing is it's never too early for palliative care. It's appropriate at any age and any stage.
There you go, folks. Never too early. Any age, any stage. Carol, thank you so much again. And thank you for those who are watching live and those who will be watching on the replay. So we'll see you guys on Monday, right back here on Tea Talks with Total Health. Take care.
All right. Thanks so much. Bye-bye.
Bye.